Hello dear students, today we are going to learn about transient tachypnea of newborn. Here is a case, a male neonate delivered by uneventful elective caesarean section at 38 weeks of gestation developed respiratory distress with tachypnea of respiratory rate 82 per minute, oxygen saturation of 94% at room air at 2 hours of life. He showed mild nasal flaring, subcostal retractions, but clear breath sounds. Lung ultrasounds revealed A line superiorly and B lines inferiorly. In this image, we can see the A line lying superiorly. These horizontal lines are the A lines and these vertical lines are the B lines. And in chest X-ray, there is a fluid in the right minor fissure of the lung. Now, question is this, that which of the following is most likely involved underlying pathophysiology of the infant's condition? Choice A, is it insufficient production of alveolar surfactant? Choice B, aspiration of meconium stained amniotic fluid. Choice C, delayed resorption of fetal lung fluid. Choice D, arrest of pulmonary alveolar development. And choice E, sustained elevation of pulmonary vascular resistance. According to this case, the neonate was delivered at late preterm stage, around 38 weeks of gestation, and the respiratory distress in choice A, insufficient production of alveolar surfactant, it is seen in neonatal respiratory distress syndrome. Here, less surfactant produced and atelectasis occurs and infant should be preterm. In our case, uh, early preterm in an RDS, early preterm in neonates will be delivered, and in our case it is late preterm. There is no history of meconium stained amniotic fluid, so this choice is associated with meconium aspiration syndrome. There is no finding suggestive of pulmonary hypoplasia. This is associated with pulmonary hypoplasia, and there is uh, no sign of increased pulmonary vascular resistance. So according to the question, there is presence of fluid in the lung, and it is due to the delayed resolution of fetal lung fluid. Now we will discuss further how fetal lung development occurs from embryonic stage to the alveolar stage. Embryonic stage, where the um, the two lung buds arises from the esophagus, and these two lung buds are lined with the endoderm, and at this stage only the basic layout of the lung form, and then the pseudoglandular stage from 5th week of gestation to the 17th week of gestation, and at this stage extensive airway branching occurs to form terminal bronchioles, and histologically it resembles like a gland. So it is named as pseudogranular stage. No structure for gas exchange occurs at this stage. And next is the canalicular stage. It ranges from 16 weeks of gestation to the 25 weeks of gestation. During this stage, lung parenchyma differentiate and vascularization occurs, and the alveolar epithelium becomes thinner and more thinner, and it started to produce surfactant from type 2 pneumocytes. At this stage, only very limited gas exchange can be possible, only towards the end of the bronchioles. At saccular stage, which is the next stage, ranges from 24 weeks of gestation to the 38 weeks of gestation. There is formation of terminal sac, which is also known as primitive alveoli, and there is formation of air-blood barrier and a significant increase in the surfactant production. And this stage is crucial for the survival of preterm infants. So this stage is the stage of viability of the fetus. Next is the alveolar stage, which ranges from 38 weeks of gestation to which ranges from 36 weeks of gestation to approximately 8 years of life. And during this stage, formation and maturation of true alveoli occurs, and there is rapid increase in the number of alveoli and capillary network, and it greatly expands the surface area for the gas exchange, and it occurs postnatally mostly. Now, during the this development, lung produces the lung cells are the mainly the alveoli are lined by the type 1 pneumocytes, which are flat cells, and type 2 pneumocytes, which produce surfactant. So these type 2 pneumocytes mainly also produce some fluid into the lungs, which is the source of amniotic fluid. This fluid is produced by the active secretion of chloride in the alveolar lumen by the CFTR channels. These channels are defective in cystic fibrosis. So these channels produce fluid in the lumen of alveoli, and sodium ion, which is positively charged ion, follows it passively, and when sodium moves from one place to another place, then it takes water with it. So water moves osmotically, and this chloride driven actively secreted fluid starts to produce around 5th week of gestation, and at a rate of 2 ml per kg per hour, and this fluid production become maximum near term at the rate of 5 ml per kg per hour. Now the pathophysiological cascade of TTN. TTN basically arises when there is no catecholamine surge. As in our case, the neonate was delivered by lower segment cesarean section. This this was elective lower cesarean section without any labor induction, without any uh, without a start of any labor pains. So in such conditions, there will be no catecholamine surge occurs, and this catecholamine surge is required for the clearance of the fluid from the alveoli of the lungs with the help of sodium channels, which are known as epithelial sodium channels. And so in the absence of catecholamine surge, these sodium channels are not activated, so the fluid from the alveolar lumen and the interstitium, mainly the interstitial fluid, is not reabsorbed into the uh, blood vessel. Second is will be asymmetric. There will be accumulation of asymmetric dimethyl arginine (ADMA), which inhibits the endogenous nitric oxide synthase enzyme, and this increases the pulmonary vascular resistance, and this further reduce the reabsorption of the fluid from the interstitium. And third, there will be reduced function of surfactant, as stated in some studies. Now the due to this accumulation of fluid, mainly which is accumulated in the interstitium of the this is the interstitium, which is accumulated in the interstitium of the lung alveoli, and this is the blood vessel. So this fluid causes the reduced expansion of this alveoli, and this causes the reduced compliance, that is the reduced change in volume of the lung with change in pressure, and this reduced compliance will increase the work of breathing, which leads to tachypnea and respiratory distress. Now the clinical presentation of transient tachypnea of newborn. Transient tachypnea is marked by tachypnea, nasal flaring, grunting, retractions in the intercostal and subcostal spaces, hyper expanded chest due to the air trapping, and mild to moderate distress. Cyanosis can be seen in severe cases, and there is clear breath sounds with no rales, rhonchi or crackles. And most of the case present at within the 2 hours of life, and these cases mostly resolve within 12 to 24 hours. But some severe cases, which are rare, can persist up to 72 hours. And during these periods, the neonate require oxygen support. Okay. Now, what are the risk factors for the TTN development? First is the elective cesarean section, which leads to lack of catecholamine surge. Second is the prematurity, especially in the late preterm stage. Third is maternal diabetes. Fourth is maternal asthma. Fifth is male neonates, macrosomia, maternal sedation and analgesia in some cases, and perinatal asphyxia, fetal distress. Now, what are the diagnostic imaging findings in TTN cases. As we have seen in the X-ray, there will be prominent vascular markings, prominent especially located in the perihilar region. This is the hilum of the lungs. These are the hilum of the lungs, and there is prominent vascular markings in the hilum of the lung, and this is known as sunburst pattern. Second is the fluid in the interlobar fissure, which is the classic finding, and mild cardiomegaly can be seen. In some case, a diffuse alveolar edema in the form of fluffy shadow can be seen, and hyperinflation can occur due to the air trapping. Now, in neonates, lung ultrasound is the modality of diagnosis which is now commonly used, and normally we can see multiple compact B lines in pulmonary edema, and in cases of TTN there will be double lung point, which is the characteristic of the TTN. What is double lung point? It is the demarcation of normal and edematous lung, and here we can see the B line which is coming vertically, and here we can see the A line. A line represent the air, B line represent the fluid. And pleural assessment show no abnormality in the pleura. Regular pleural line can be seen with no consolidation attached to it. Now, what are the key differential diagnosis of TTN? First is respiratory distress syndrome. Respiratory distress syndrome is a progressive disease. First is the respiratory distress syndrome. It is seen in preterm infants with progressive respiratory distress, chest X-ray show ground glassing, and air bronchograms. It is due to the reduced surfactant production by type 2 pneumocytes. Next is the meconium aspiration syndrome. There will be history of meconium stained amniotic fluid. Coarse crepitations can be heard on auscultation, and there will be patchy infiltrates in chest X-ray. Third is neonatal pneumonia or sepsis. In these cases, history of maternal infection, risk factors will be there, and the neonate will be lethargic with the temperature instability and poor feeding, and there will be elevated inflammatory markers. Fourth is the persistent pulmonary hypertension, in which severe hypoxemia and which is disproportionate to the lung disease can be seen, and there will be pre and post ductal SpO2 difference of more than 10%, and it is diagnosed with the help of echocardiography. Fourth is the pneumothorax. There will be sudden deterioration in the respiratory status and unilateral decreased breath sound heard on auscultation, and chest X-ray revealed hyperlucent lung fields in the absence of lung markings with some mediastinal shift can be seen on chest X-ray. And the sixth is the congenital heart disease, which are diagnosed with the help of echocardiography findings. Now come to the management of TTN. TTN is a self-limiting disease which gradually resolves by itself, and during this period only the supportive treatment is necessary in the form of proper feeding, and most infants tolerate the oral feeding. However, when respiratory rate is very high and there is significant work of breathing, then enteral feeding should be holded, and start the orogastric feeding or IV fluids. Fluid should be given only in restricted manner. In term or late preterm infants only at less than 65 ml per kg per day, and in preterm less than or equal to 80 milliliter per kg per day. Use of diuretics is not recommended, and respiratory support only minimal support is required, and which can be given with the use of hood or nasal cannula to maintain SpO2 around 90 to 95%. Rarely it requires FiO2 more than 40%, and if distress persists and oxygen requirement increases, then nasal CPAP can be used to reduce the work of breathing. And if this respiratory distress persists, then we have to evaluate for other things like RDS, respiratory distress syndrome, or sepsis. And in this image we can see this is the nasal CPAP used in newborns. Adjunctive therapy which have uncertain role are beta agonists like salbutamol and inhaled steroids. These are not routinely recommended and have no supportive evidence. Overall, TTN is a self-limited condition, and management is aimed for supportive stabilization while excluding other serious causes. Now, come to the summary. TTN is the most common cause of respiratory distress in term and late preterm neonates. It is caused by delayed clearance of fetal lung fluid due to the reduced ENaC activity. Onset occurs within first 2 hours of the life with tachypnea and mild respiratory distress. A strong risk factor is the elective cesarean section without labor. It causes reduced or absent catecholamine surge. Chest X-ray show hyperinflation, perihilar streaking or vascular markings in the form of sunburst appearance and fluid in the fissures without any sign of consolidation. And USG show the double lung point. And it is a self-limited disease or condition which resolves within 24 hours to 72 hours of life with supportive care only. So that is all for today. Thank you.